our data. All health data is now locally hosted, adhering to our data protection laws, ensuring that the health records of Kenyans are secure, are sovereign, and are used primarily for the benefit of our planning and resource allocation. Pillar number 3, Honorable Chair, Honorable Speaker, and Honorable Senators, is human resource for health. No system can function without the hands that heal. We have ensured that all UHC staff engaged under the previous contracts continue to offer service without disruptions. We have all resolved all the standing issues regarding medical interns who are now being paid strictly as part of the collective bargaining agreement rates, ensuring that we treat our future doctors with the dignity that they deserve. And on UHC staff, Honorable Chair, Honorable Speaker and Senator, I really want to bring to the attention of the Senate that we have agreed with the National Treasury, Public Service, that these people must be transitioned now to the counties, and the salaries and their remunerations must be seen in the division of revenue bill that will come before as part of the equitable share. At the grassroots, we have formally recognized, paid, equipped, and digitized 107,000 community health promoters, transforming them from volunteers to frontline soldiers in preventable health. To sustain these grassroots heroes, I have specifically requested the support of this Senate to implement a joint national and county co-payment framework for their social health insurance. That come July, both the national and the county governments co-share that we give our frontline 107,000 community health workers a premium health insurance. The fourth pillar is on health products and technology. We are reforming KEMSA, Honorable Chair and Honorable Speaker and members, into an agile, transparent, logistic entity that uses digital tracking to secure the last delivery of medicine. Many Kenyans now were telling us there are no drugs at the last mile. I urge you, Honorable Senators, to actively support and encourage the county facilities to purchase their medical commodities directly from KEMSA, as we have adequately capacitated and supplied authority, and now its refill rate is at 89%. But, Honorable Chair, I think it will come under our discussion, Honorable Speaker and Chair and members, that the law you passed, FIF, is not being implemented very well. Some of the money are being returned back to the county treasuries. And there's a report we have to that effect. The money must stay in the health facilities. It will help them buy drugs. It will help them recruit healthcare workers on locum. It will help them improve on their infrastructure. So the Senate should help me enforce the implementation of the FIF Act. Honorable Senators, I must highlight the strategic importance of the USG-Kenya health collaborations. This partnership provides over USD 300 million annually in support of our malaria, HIV, and TB closest programs. As we move towards the sunset of some of this international support, we are pivoting towards local manufacturing of health products to ensure our long-term health security. To ensure specialized services reach our counties, we're implementing the National Equipment Support Program. Critics have attempted to compare this with the all-rigid, flawed management equipment service they call known as the MES. Under the MES, counties were inadequately consulted. But under the NEST, the National Equipment Support Program, we have signed intergovernmental partnership agreements with all the 47 counties. NEST is a very strict fee-for-service arrangement. We only pay for utilization. The county government does not buy, the national government does not buy, the vendor is paid based on that strict fee-for-service. And that reimbursement will be done through the national through the Social Health Authority. We have already invested under that NEST program, when I quantify the equipment in our county hospitals, close to about 6.18 billion to install modern diagnostic machines like CT scan, digital X-ray in 120 county facilities. And let me give an example of King Fahad Hospital in Lamu. Today I stand here, and I have been there. King Fahad Hospital has a fully fledged running ICU, both even for pediatric. Today it has an oxygen plant, today it has a CT scan, today it has a private wing, and many of the people in Lamu Island used to travel all the way to Mombasa. Today they don't need to travel, and that happens in many of our counties. Our referrals numbers have reduced drastically by 60%. We have also heavily invested in specialized capabilities and maternal survival. Under the Every Woman, Every Newborn, Everywhere agenda, we have launched a rapid result initiative in 26 high-burden priority counties. We are drastically strengthening emergency obstetrics care and blood transfusion service, because no mother should die while bringing forth life. Honorable Senators, let me be very clear today that the next agenda, all of us as leaders, we need to deal with is maternal and new child-born mortality rate in our country. Mothers are dying. Children are dying. When mothers walk to hospitals, they are not patients. They go to health facilities to bring life. They should not die. And that's why we started the Rapid Result Initiative in 26. We have mapped out the country. We have found out 26 counties have very high burden of maternal mortality rates. The Kenyatta National Hospital has reached a world-class milestone, I want us to give, by establishing the state-of-the-art HLA lab for organ transplant matching, effectively ending our reliance on expensive foreign laboratories and cementing Kenya as a regional hub for medical excellence. A number of tests that we used to send to CDC Atlanta, to South Africa, today can be done at Kenyatta Hospital. Beyond our borders, we are positioning Kenya as a leader in global health security. Through the Kenya National Public Health Institute, we are expanding our laboratory networks, emergency operations centers, and we are building a resilient system capable of detecting and responding to pandemics long before they reach our borders. We have just this week reduced the restrictions for our citizens crossing to Ethiopia after WHO and the Ethiopian Minister for Health have confirmed to us that Marburg is no longer a threat. Honorable Chair, Honorable Speaker, Honorable Senators, what are the challenges and what are the legislative interventions that we require from the Senate? While our progress is undeniable, we face critical challenges that require your direct legislative and budgetary intervention. The facility improvement financing implementation. While Parliament, the two houses enacted the FIF Act to ensure funds are raised in hospitals, stay in hospitals, we are facing an implementation crisis. Counties are increasingly substituting their own health budget allocation with FIF revenues. What do I mean by that? Today, I am sure the Public Investment and Accounts and the Health Committee will agree with me. The own source of revenue in our counties, the health sector accounts for between 60 to 70%. And because of that, some counties don't want to allocate the ordinary resources from the equitable share to health. And two, as I said, we're facing challenges with how the FIF is implemented. I know I will have issues with the Council of Governors because I have a session with them next Tuesday. But I think we must face the reality and we must tell each other, however painful it is, because Kenya must change. Revenue retained by facilities must be treated as supplement to and not as a substitute for the equitable share. 2, legislative harmonization. To secure the standard of care, I bring to your attention a bill before the National Assembly, the Quality Healthcare and Patient Safety Bill, which is currently before the National Assembly's Departmental Committee on Health. We need your support when it arrives there to expedite that passage. Furthermore, there is a pressing need to review and harmonize the existing health legislation to ensure conformity with the Constitution and the UHC agenda. This includes urgent amendments to the Health Act, the Public Health Act, the Cancer Prevention and Control Act, the Pharmacy and Poison Act, the Mental Health Act, and the Nuclear Regulatory Act. Just to go back to the Quality Care and Safety Bill, Honorable Chair, Honorable Speaker, Honorable Senators, care for many years has not been defined. The care of our patients has never been defined. You will see there were 2 mothers, 3 mothers sharing one bed. You'll see patients on the floor of hospitals. That is no longer the case. And how did we solve it? We solved this using the digital superhighway. As we sit here, we can tell the bed capacity of each hospital in our country. And we introduce in the system bed access rule. And every hospital can only admit based on their license. If their license has 50 beds, they can't admit 51. So this bill is so critical because it's defining care, it's defining safety, it's defining how our patients should be treated. The patient should be the boss, not anybody else. Lastly, exchequer release and budgetary support. We need support from the Senate. Finally, to sustain this momentum, Honorable Chair and Honorable Speaker and members, and clear the backlog, we require budgetary intervention, which rely heavily on your support. We need an exchequer release of 5.9 billion for PHC fund to clear pending claims and ensure seamless, free primary health care. It's budgeted, it's not been released. Dr. Mercy has to pay PHC for the month of October, November, December, and January. I had an engagement with the Treasury. They say they will release before the end of today or Monday, but still, I think the Senate must be cognizant, and I must tell the Senate that. A supplementary budget of 11.9 billion to cover the projected PHC deficit up to the June of 2026. We have also allocated 2.04 billion to fully operationalize and support maternity package to safeguard our mothers and newborns, particularly in level 2 and level 3. When the architecture of the Social Health Authority benefit package was done, level 2 and level 3, where a lot of our mothers in the rural areas used to go and access to deliver, were left out. Now, we have quantified and we have looked at the financial burden, and at the summit of 10th December, it was agreed that now our mothers should deliver at level 2 and level 3, and SHA should get the reimbursement, and SHA will get 2 billion to fully operationalize that. Finally, honorable senators, the state of our healthcare is transforming. We have moved from a defined NHIF to a surplus generating SHA. We have stopped the hemorrhage of public funds to cartels and redirected it to Mwananchi. And I request your continued support. There are many things I can say that I've never seen in my entire life in public duty. You have seen the DPP flagging and charging 9 facilities, their directors, and even some of the staff of the Kenya Medical Practitioners Council. The place was rotten. We have a pending bill of NHIF. And this is how we agree to deal with after we do validation. We have said 0 to 10 million of the old pending bill of NHIF, amounting to 5.3 billion, accounting for 95% total bill of legacy bills of NHIF, will be put in a supplementary that will be presented to Parliament next week. The balance we have agreed after we are doing validation and scrutiny will be put in the budget of 2026 to 2027. 2026. So it's not always a sense of and also a victim.
Yes. So everywhere I go, Kenyans were asking me, what about? There are many facilities. Let me be very honest. There are many facilities facing challenges because of the legacy debt of NHIF. But now we have found a solution. Robert Judge, just to finish the current issue we are dealing with, and we are just giving you a tip of the iceberg. Fraud in healthcare is about 30% globally. Today, even our colleagues in the private medical insurance, they're facing the same fraud. In fact, if social authorities suspend a facility, all the other insurance companies will suspend the next minute. That's how fraud is. We are now investigating parents who are submitting claims of their dependents, their children. One household is submitting 137 children. Another 140, another 150. When I submit that list next week with the facilities to the DCI, it's a difficult job, but I have to do. It's a difficult job. I looked at it last night after the system, so that is some of the things that we bedevil every day. We have a facility. I don't know where the senator of Bungoma is here. Yeah, we are monitoring on 24 hours a facility in your county, because the system picks and profiles. So now these Kenyans who are submitting, I mean, I think the person with the highest number of children in our country must have been Kukudenja. Kukudenja had 140. Nobody else has reached there. So we are facing all that, but we are ready, we are willing. I have never missed any session of the Senate, both plenary and committee. I have never, the clerk is my witness, I signed statements. I give it priority, and I am ready, willing to answer any question this afternoon. Thank you, sir.
Asante sana. Makofi mengine kwa waziri. Waziri, some of your statements you should not make categorically that we have not reached Akuku's numbers. Where myself and Senator Wakoli come from, we don't count children. So you should not be too sure. Now, we are going to go into quick plenary. It's 1:15 midday. Please, members, we agree we are going to do only 30 minutes. Waziri, I am going to allow you to call two members from your team because of the space here, but from the Senate, the chair of the Health Committee has arrived. Senator Jackson Mandago, please join us here on stage. You want Dr. Masi Mwangangi and who? And P.S. Oluga. Please come and join us here. But even as they come, Waziri, there'll be need for a lot of clarifications from some of the things that you have spoken to. You have answered some of my concerns, because when you speak about 12 billion that you've prevented in fraud, we expect to see commensurate prosecution. We want your clarification whether these 1,186 files that you have forwarded to DCI represent the entirety of the amount of 12 billion shillings you claim you have stopped as fraudulent claims. Secondly, Waziri, you have to tell us where the problem is in the legal chain. You know, if you submit 1,186 files, and then we have only 30 cases that the ODPP is presenting for the problem. Waziri, on your speech as well, you have spoken about UHC workers, and we have heard you repeat this severally, because I've heard this before, that you had agreed with the Treasury or the county governments to second this stuff to the county governments. We remember, Honorable Speaker, county governors saying they don't want these people. I don't know if it is me or that is the case, Waziri. You need to clarify to us, because the governors are saying without the money from Treasury, they are not going to take this stuff. Waziri, you have not touched on facilities reimbursements, which continue to be slow. You clarify for me this Lipa Sha Pole Pole. Is there a threshold that needs to be met by that Mamamboga before they access services, or immediately they put in the first installment, they are good to go? Clarify to us also, Waziri, what procedures you have put in place or mechanisms. You have said that when people travel outside Kenya to seek health care, they have to follow certain procedures. I don't know how many people in this room, including the senators, are aware of that process, and what mechanisms your ministry has put in place to sensitize Kenyans on following these proper procedures, because we see very many cases of people stuck abroad. Then on the NHIF staff, we have had complaints, Waziri, that there are people who are facing those fraudulent allegations, directors who have actually found their way back to SHA. You need to tell us what is happening there. And I can see Dr. Uma Oluga is here on stage. He has a history of union work. We want to know what policy interventions you have put in place to stem the rising and incessant cases of industrial action in the health sector. As the Senator of Nairobi standing here, we have had a strike for clinical officers in Nairobi. I think it is now day 66 or something. Please address the policy interventions that you have put in place for us to be able to deal with these industrial actions. And the key complaint is failure by the ministry and the county governors to do what? To honor the agreements that they signed, the collective bargaining agreements that they signed. So we will note those, and Waziri, you will decide who answers what. But honorable colleagues, just 1 minute, please put your hands down, because the chair of health is here. With your permission, because he was a discussant, can he please go first? And Senator Mandago, because of the interest from your colleagues, you had been allocated 15 minutes, but by executive fiat, I am cutting it down to 5 minutes. Or you want him to go last? Okay, Mandago, is that okay? Aya, 20 cars. Let me start with VIP, please. Give the mic to Senator Crystal Asige. There has to be a roving mic, or are there mics on the table? Yes. And let's keep them brief and straight to whoever it is you want to address your question.
I use which one? This one, right. Thank you very much. Thank you so much to the session chair for an opportunity to ask my questions to the CS. Thank you, CS. I really appreciate your presentation. And because I represent disability, mine will be, of course, on that. My office has received multiple reports from parents and caregivers, including one from Chanzoya just yesterday, whose 28-year-old with disability was informed that he could not be covered under his parents' SHA anymore and must now pay independently, even though he has a severe disability. Under the Constitution, CS, Article 54 provides that persons with disabilities are entitled to dignity, respect, and access to facilities and services, including healthcare. And the state must progressively ensure these rights are realized. Now, in line with this constitutional guarantee, the Persons with Disabilities Act 2025 that I sponsored just last year was enacted in May 2025 to give life to Article 54. This act explicitly states that persons with disabilities have a right to the enjoyment of the highest attainable standard of health, including health-related rehabilitation services, without discrimination on the basis of disabilities. So, the Act further provides that persons with disabilities are entitled to free medical care and treatment in public health institutions, and national and county governments must ensure these services are responsive to the needs as per the law.
Senator, please go to the questions, please.
Thank you.
There's a lot of interest in the room.
Right. My questions are as follows. I want you to clarify, CS, kindly, how SHA interprets and applies disability rights in health coverage decisions for people with disabilities as per the PWD Act of 2025. 2, how does SHA align its operational guidelines with the Persons with Disabilities Act of 2025? Also, how is the ministry engaging parents and caregivers and disability organizations to meaningfully put together dialogue and regulations to give life to this act, so that they can make sure that they can, their needs are addressed?
Thank you,
and
Senator,
just one more, kindly, because I won't speak again.
Not hold.
Okay, fine. And also, I wanted to find out, why does SHA not include assistive devices for people with disabilities, even though this is part of healthcare for people with disabilities to be able to function? And lastly, when will our delegated legislation committee get some regulations from the Ministry of Health, because we are yet to see regulations to operationalize the PWD Act as per your ministry? Thank you.
I wish we be fair to each other. Just one question per member. Senator Murango, then I come here. Senator Murango, all of you will have an opportunity to ask a question. Please be brief.
Chair, I'm Senator Newton, not Murango, but I represent Muranga. So my question to the CS is, what was the rationale of moving from NHIF to SHA? Because we would have been able to sort out the problems that were identified with the NHIF without necessarily moving from NHIF to SHA, because we have a problem with the 104 billion that was spent to move from NHIF to SHA. Was it not possible to sort out the problems in NHIF without necessarily getting into a new system? Can I?
Thank you. That's enough, Mheshimiwa. Beatrice, Senator Beatrice, and then we will have Senator Chute from here.
Thank you, Senator. CS, the impressive data we continue to post to Kenyans, like you did this morning, to me, may not matter so much if Kenyans do not get uninterrupted services from the medical centers. And I say this irrespective of whether the functions are devolved or not. Kindly let me know what measures you are putting in place to ensure that members of the public get continuous services from hospitals. Two, the last, Senator Sifuna, health is so key to us. The last is on SHA. I want to start by saying that SHA is working, and I can confirm. But there must be structural issues that needs to be addressed by the ministry. One of them, I suspect, is the waiting period. Like all insurances, Kenyans just have the practice of paying today when they are sick in hospital and making a claim tomorrow. Could that be a challenge that is getting us into the problems that SHA has? Kindly address the waiting period.
Thank you, Senator Chute. And as, before you go, the governor for Mombasa, just a minute, leader. Everybody will get to us. The governor for Mombasa, who is also the chair of the health committee in the COG, has joined us. Governor, with your kind indulgence, join us on the podium here. Yes, Senator Chute.
Thank you very much, Senator Sifuna. My question will be very specific, and it is on the former employees of NHIF. I asked this question when the minister came to the Senate, and I'm asking again the same question, is to know a timeline on how many employees are going to be accommodated in SHA, and the remaining employees, how long will it take to accommodate those employees also, if we can have a timeline, so that people, employees, former employees are complaining, asking when are we going to be accommodated in other institutions, if they can give us a program.
Thank you. We are back here, Senator Muma, then we will have Senator Utata, Senator Kinyua.
Thank you.
Please,
thank you, Chair. My first question, CS, I'm disappointed that your entire presentation has not mentioned anything about local manufacturing. There is no way we will ever deliver on UHC if we don't support our own local manufacturers to reduce on the costs of pharmaceuticals, health products, and all those issues. I would want to know what is being done to support our local manufacturers. Just one more. I saw your passion around RRI and reducing maternal mortality. CS, a lot of the mothers are child mothers, and SHA is not supporting child mothers. SHA has decided that they cannot be covered under their parents' insurance. When the 9-year-old is defiled and gets pregnant, then she must be assessed on her own because she's going to be a mother. I think that is a mistake. What is the ministry doing to ensure that every adolescent, pregnant mother, or one who has delivered is catered for?
Senator Kinyua, we'll come back. We are going this side, please.
I didn't.
Okay. Proceed.
Okay. Waziri, I didn't hear you mention the effect of the reduction in donor funding in the ministry. I didn't hear you mention that. Secondly, also you mentioned about the paneling of the hospitals which are outside this country. Then there's something that you mentioned very interesting about partnering with the hospital in this country. Do you deal with the level? Which hospital? Is it level 4, which is partnering with the hospital which is outside the country? And lastly, I just want to know, health is devolved. But you did mention that from where you sit or from your dashboard, you can tell any hospital that is admitting the capacity. At what, may I know what platform you use to know that?
Thank you, Senator Kinyua. We are taking the last batch, then we will come back for the second round. Let's not overwhelm the panel. Senator Issa and Senator Tabitha Mutinda. From here, then we go to Senior Council. Please, we will come back. We have to move across the room.
Waziri, just a quick one. I have a patient from my country. I come from Kwale County, Senator for Kwale County. I have a patient, and this patient has brought this attention to my office. He's suffering from cancer. You know very well, Waziri, cancer is really killing people in this country. I want to know the procedure. How can this patient be treated out of the country? Because her cancer stage is very critical condition. And she wanted to go to abroad. But what is the formalities now? You said there are some new guidelines to a patient to be taken to abroad. Kindly please furnish us.
Thank you so much, Senator Sifuna. 2 questions very quickly. The other day we were handling the PBS, and we realized that the ministry has added 20,000 CHPs. So as to, 13,000 CHPs. The budget still remains at 3.25 billion. How are you going to cater for the difference or the increment of the 13,000 CHPs? What is the methodology that you're going to use to ensure that these CHPs are distributed in the 47 counties, or what the plan? Lastly, very quickly, there has been the delay in SHA reimbursements to the county hospitals. What's the plan? What's the strategy to ensure that hospitals are able to continually deliver their services to the people?
Thank you, Senator Mogeni. We'll close that session. question, then we'll take the next batch.
Yes.
If you have asked a question, you will ask again. If you have not asked, we'll give you opportunity. Say them again.
Yes, Waziri, I heard you declare that nepotism has no room in your ministry. Now, on the latest share recruitment, can you give us the figures? The people who are recruited, how is the ethnic composition? I think we are digital. You can get these figures. The CEO is here. Can you give us the figures now so that we see whether you are walking the talk? That should be tied with the 558,000 Kenyans that are being supported by the national government. Can we know how these 558,000 families are spread in the 47 counties? Finally, there is these Kenyans called the indigents, or the ones who pay the minimum share contribution of 660,000. Waziri, why are these Kenyans being denied admission to private hospitals when the facilities at counties are full? Like I've just checked on your platform, Nyamira has a bed capacity of 255. At 12 p.m. today, they are at 249, meaning if they admit the next 6, it will be full. Now, once it's full, the ones who seek admission in private hospitals are denied admission. Why is the government denying these Kenyans admission into private hospitals when the county facilities are full?
Thank you, AC. So, Waziri, we will take those many interventions, and you will determine who or among your officers can answer what question. Over to you. There's a mic.
Thank you. Let me start with you, Chair. I think let me start with the UHC staff. UHC staff, the problem was the division of revenue bill and when it's supposed to come. As of today, the UHC staff earn the SRC rates with all the allowances the national government is paying. At the 10th of December summit chaired by the President with the Council of Governors, it was agreed that a committee was formed, chaired by myself and my colleague, the chair of the Health Committee, the National Treasury, the Public Service Commission. The money will be factored in the division of revenue. Once that is done, then the counties will start the process of transiting them. The only problem with the counties was the assurance that the money for future is that's it. On the 12.7 billion, these are like somebody who wants to steal from your supermarket and you arrest him. So we have, I can give you the breakdown of this 12.7 billion. 58% of that mainly are because of missing documents that are legal. All of you senators know that when you go to see your doctor, the claim form is a legal document. It's in the SHA laws. If a facility submits a document for reimbursement without a claim form, that is a rejection, that is fraud. 2, a claim form, all of you senators, when you go see your doctor, the first part of the claim form is filled by you. The second part of the form is filled by your doctor. The third part of the claim form is filled by the hospital administrator. Where you have a situation that the claim form of 500 claim forms are filled by one person with one same handwriting, one biro, that is fraud and we will not pay. Second, and more importantly, if you claim for a maternity, there is a legal document that must be part of that documentation, and it's called birth notification. Birth notification confirms a child has been born. So if you don't provide that birth notification, that claim is rejected. And also, let me tell you, and I'm sure in the Senate there are doctors, and most of us even sitting here are doctors. There are facilities that are reporting that they are claiming for 300 maternity reimbursement and all of them are C-section. That's against international rules. It's against WHO. So that facility is flagged by the system. And we have many. We have situations where we have inadequate discharge summaries. We don't know when you have discharged the patient. We have a situation where every doctor who went to school, there's something called theater notes. When you're going to a theater, a patient is being taken to a theater, you must have seen there's a file. That's the theater notes. So when you're saying you want reimbursement for surgery or procedure, and you are not attaching theater notes, that to us, the system will flag, it is. So there are number, clinical, judgments and all these. But to give you the real numbers of these 12.7 billion, Honorable Senator for Nairobi, private facilities are the highest with 59%, accounting for 7.4 billion. So a lot of the fraud is in the private health facilities. It is followed by our county facilities that account for 21%, about 2.6 billion. It's followed by faith-based facilities, 11%, 1.4 billion. And lastly is the national referral hospitals. Kenyatta National Hospital, Kenyatta University Teaching and Referral Hospital, Mwai Kibaki Teaching and Referral Hospital, Madare Teaching and Referral Hospital, Jaramogi, all these, MTRH. But of course, of all these referrals, there may be one or two the highest. They account for 9%, 1.1 billion. That tells you we are not discriminating. It's across the board. Honorable Senator for Nairobi, I'll leave Mercy to talk about Shah Lipa Pole Pole. I'll leave for Mercy to talk about facility reimbursement and foreign procedures and protocols. And most of these things, as he answers, are in our website. If you go to our website right now, those protocols, those procedures, all these things, the benefits, all of them are in the website of SHA. But we are under obligation to make sure that the Kenyan. On the issue of the industrial action, I'll leave it to my peers. He is well versed, he's very competent on that. I'll also leave the issue of disability is very controversial vis-a-vis the law that was passed. This is an insurance fund. It has to be sustainable. So I'll leave it to Mercy. We had done something about that. Honorable Muranga is not here. Senator from Muranga is not here. Yes. I think the transition from NHIF to SHA was a legal transition, and he participated in the Senate. I think he can answer better that question. I was not in the Senate. He should have raised that. What made NHIF to be closed and SHA to start? It is the first thing that was done was to change the law. And the Senator for Muranga was there. So I don't think to answer that question. I'm only implementing what the law, what you people have passed. To be very honest, Chair. Every day, if you change the law tomorrow, I will vote do. So, Senator Newton, I think if I'll look for the answer to see his contribution. Yes. So on the 104 billion, and I want to answer today this very categorically. There is no 104 billion the Kenya government is paying. And if it is paying, it should be seen in the budget. It's nowhere in the budget policy statement. It's nowhere in the budget. The consortium have developed 38 systems. A system for citizens to access healthcare called Afya Yangu. Today, if you go to that app, Afya Yangu, everything about the citizens, Kenyan citizens, will go. For doctors, we have Practice 360 to see the doctor, his credentials, whether his license is valid, whether his scope of practice is right, is practice. For KEMSA, so we are 38. So the fees paid by those system owners is what the consortium that built under the DHA, after confirming DHA and the PS as accounting officer confirming, they will be paid. So the people of Kenya are not paying. There are people who are saying that we have spent 104 billion. That is a fallacy. That is untrue. That is not there. And I really want to say, Honorable Beatrice, very impressive data, uninterrupted service. I agree with you. We have counties where, or referral hospitals where, or private where, in one way or the other, there is uninterrupted facilities. We can give you the 10 best performing counties. And allow me to say it. Mombasa is #1. Kisumu is doing very well. Bomet is doing very well. Elgeyo Marakwet, Kirinyaga, Nakuru, Embu. I can give you the bottom 10. Yeah. Yeah. The bottom 10, Nyamira is one of them. Samburu, Garissa, where I come from, Mandera, Wajir, Marsabit, Turkana. Yeah. Nairobi is one of the best. Kiambu is one of the best, apart from the strike, which I'll come to. But now that it's developing, the bottom counties or the middle counties are now working very hard to dislodge Mombasa, which is #1. And I hope the governor will protect me when I appear before the Council of Governors. Already they have too many problems. But I'll run to the Senate. SHA is confirming strategic issues, waiting period. Where waiting period is happening is where some facilities want cash. And we are flagging them off. Yes. They don't want, so they tell the Kenyans, citizens, and we have now picked those facilities. They tell Kenyan the system is low, SHA is not working, wait, and so that the patient gets a bit fatigued, and then he pays from his pocket. But we'll get it. Senator Chute, NHIF had staff of over 1,800, over 1,800. SHA has less than 850. The reason is because of digitization. Half of those staff left because their work has been taken by the digital superhighway. What have we done to those staff? Those staff, so far 250 of them have been transitioned to public service out of their own volition. And they choose which ministry, which agency, which parastatal they want to go. Some are in the Ministry of Health. The only thing I just want to work, and all of them, apart from the ones who will be recruited by SHA, and the court says SHA must give first priority, but must be on merit. Those who will remain, they're transiting to public service, to salary. So the salary that they were earning at NHIF is the salary that they will earn where they will go. That I commit to the Senate. That is the only thing, and we want to put it in the budget as they transit. And I think I've answered the Honorable Chute's question.
It's about timeline. How much time will it take? Timeline.
No, I think the last recruitment of SHA will happen in the next 2 months. Then, so far, there are 250 who said we want to leave. So they didn't apply for jobs within SHA. The rest, before June, because their money must be transferred to the ministries and sagas they will go to, we will transfer them. Senator Muma, local manufacturing is very key. Our president now is the chairman of African Union on local manufacturing. We have just come back from AU. 40 of our pharmaceutical companies, big companies, including one of the best in Kilifi called Revital, are exporting to the whole world, including US and India. But there's something which was missing, the accreditation of ML3 by WHO. And let me say it, I am the 23rd minister since independence. I think people failed. Those who are before me failed. But I want to assure the Senate, by June of this year, Kenya will attain ML3. Once we get ML3, the last inspection team of WHO will be in the country next month. And by June, they will give us, and we want to make Kenya a regional hub for local manufacturing. I agree with you, we learned from COVID, we cannot wait for vaccines from other people. We must produce our own vaccines. So that in the event, unfortunately, if an epidemic happens, we have our own vaccines. But I agree with you. On the RRI, teenage mothers across our country are fully covered by the Social Health Authority. All of them across the highest premium Social Health Insurance Fund. So far, 50,000 teen mothers have accessed the social health, and we can provide the data. But we want the leaders to help us, and our county leaders to mobilize those teen mothers and allow them to register because they have no ID. And the counties with the highest number of teen mothers, I can give. Yes, they are known. They are known. Senator Kinyua, I think your answer on the empowerment of the foreign hospitals, we will, I'll leave it to Mercy, but they must be at level 6. Those who will come and empanel, they must be, but Mercy will give more. And how do we detect all this? Through the digital super highway. There's a lot of information it's giving us. Honorable Boy, Juma Boy, patient support guidelines. I'll leave it to the same, I'll leave it to Mercy. To Honorable Mutinda, it's foreign to me. There's no 13,000 CHPs we are recruiting. I don't know where you got the information.
CS, I'm the Vice Chair of Finance and Budget, and we were just looking at the PBS last week. We just tabled it. And we currently have 107,000 CHPs in the country. The PBS talks about that the ministry is looking forward to increasing another 13,000, which brings into 120,000. The budget still remains at 3.25 billion. So how are you going to cater for the difference in terms of the 13,000 CHPs?
Let me make it very clear. I am the Minister for Health. What I have presented before the Health Committee of the National Assembly is money to replenish the 107 CHP, their kits, and their jackets. What they carry has already expired. So we want money to give them the equipment and to replenish. So the 13,000, if it is in the BPS, when we go to the real estimates, my priority is the equipment, my priority is the jackets, which are fading. So treat it as something from the National Treasury, it's not from the MOH. And I can avail what I have presented to the committee on...
please kindly avail to the Committee of Health, where I also serve.
Order. I'll throw you out. I think to avoid the back and forth CS, if there's a question that has not been answered to your satisfaction, we will have opportunity to clarify, but let's not have a back and forth.
But Chair, I think it's good that I say it very clear and categorical. 13,000 new CHPs is not from the Ministry of Health. Honorable Senator, my good friend from Namira.
Session Chair, just a minute. Because I'm the chair for health. CS Duale, I thought there is a collective responsibility for cabinet. So if National Treasury submits, and it is an authentic document, I sit as the chair of that committee, and that is the paper we discussed. I think it would have been appropriate to say you will have to look into the document. When you say categorically, then I thought you people are serving one government, but I don't want us to go there. But just know once the documents are submitted from government and it talks about Ministry of Health, then it is assumed the data that went to Treasury was from the Ministry of Health. And if there's a problem, you can quietly go and sort out with your colleague in the Ministry of Finance.
Anyway, the budget policy statement is a framework. The real thing is the estimates. But because I'm appearing before the Senate and I'm unanswered, that is foreign to me. That is not my document. I have not asked for 13,000 CHPs. What I've asked for is the kits and the jackets, and it's in the Hansard. And if there's a chair of health calls me tomorrow, I'll say it on record. 13,000 is not from my ministry. So the Senate should call the CS for National Treasury. Honorable Senator for Nyamira, my good friend, up to today, and we can provide. First, the list that was circulating was AI generated, was fake. I can say it with confidence. So far, we have only employed 17% of the 100% staff we are supposed to recruit for NHIF. So 83% we have not recruited. And unlike any other agency, what we recruit, the shortlist, we put it on our website. It's a public document. After the shortlist, it must have regional balance, ethnic balance, it must have religious balance, gender balance. And I want to assure this August House, and Mercy will also talk about it, we have not recruited. It's only, I think, less than 100, maybe the directors. And if you look at our directors, they represent the face of Kenya. And they were interviewed, and they passed the exams. I don't sit, the ministry don't sit, we don't oversight, it's the board of SHA. The 580 indigents paid for, these are Kenyans we have picked from the social health, the social protection data. The ones that receive the 2,000. Putting into consideration the vulnerable, the OVCs, people with a disability, and we are ready and willing, under the guidance of the Speaker and the session chair, to table that list. It is from every constituencies. Of course, even the social protection list is not uniform. There are some parts of our country where there are more members in the social protection. But the 580,000 we have paid for has been picked from that. I think Honorable Mageni asked about the bed. What happens is that from our dashboard, and governors have dashboard, Governor Nasir is here, when the hospital bed occupancy is getting full, our digital system shows red. And we advise the hospital either to do two things. Either to discharge the patients who are okay, to create bed occupancy, or to transfer the new patients to the nearby hospital. The system will talk to that hospital. But because there's more money in inpatient, and a lot of the rejection was facilities who are turning outpatients, Kenyans, to inpatients, there are some hospitals we have even closed in Nyamira and other parts of the country because of turning outpatients into inpatients. So there is a rule that we talked to. There's an SMS that, and when it is green, we also tell you you have got about 30% bed occupancy. But we want to stop Kenyans sharing beds or on the floor. And Mr. Chairman, if you agree, if you allow me, why were Kenyans sleeping on the floor? Why were two mothers who don't know each other sharing one bed? Because in the former NHIF, the they were charging, they were paid for those even who were on the floor. But under SHA, we only pay for those who have the right care and they have got one bed on themselves and nobody sleeps on the floor. SHA will not pay. I think, Chair, I think I finished. I just wanted to ask Mercy and the PS to answer the questions on their side. I'll start maybe with Mercy, which had, PS. PS can start because he's his only one, I think.
Thank you, CS, and to Honorable Speaker and Session Chair and Senators. Good afternoon. Mine is a very simple question about the issues around industrial action. And just to assure the Senate that we have taken very decisive action around human resources for health. It's one of the pillars that the CS had mentioned, and implemented the collective bargaining agreements, actually all of them in full, including the issues around internship. Just on Monday, there was the last one, which was the clinical officers, which was signed on Monday. And the reason why the Ministry of Health signed it later is because more than 7,000 clinical officers are county employees, and only 153 are employed by the Ministry of Health. And so there was need to harmonize so that the county governments agree, sign with the clinical officers first before the Ministry of Health could sign. And so the assurance of the Senate is that the health workforce is a critical component of achievement of universal health coverage. We've presented the issues of UHC here, which we require also the support of the Senate to ensure that the request of the governors in the summit, particularly to mainstream in the equitable share, is fulfilled, so that then we could also transfer. Otherwise, we, I think, are in a good space when it comes to health workforce.
Thank you, CS. Honorable Speaker and honorable members, I'll go through a section of the questions. Let me start with the specialized overseas treatment. This package will be active in the coming week. And so far, we have a list of providers who I will read out to you, who are the hospitals that Kenyans can now go abroad and access services from. The first hospital is Manipal Hospital. We have Medical Point Izmir Hospital. We have Asibadem Group of Hospitals. This will all be on the website, so it will all be available. I'll talk about the countries as well.
I think Dr. Hari just mentioned the country where the hospital is.
Right.
Just quickly.
So we have Manipal Hospitals from India. We have Medical Point Izmir Hospital, India. We have Asibadem Group of Hospitals, India. Yes, Turkey. We have Yathareth Hospital, India. Saitacare Hospital, India. Kim's Hospital, India. Sarvdoya Hospital, India, and Sage Group, Saudi Arabia. The process of enrolling hospitals for overseas treatment is continuous. We'll be using an SPP procedure, and so this list will continue changing as more and more providers apply. But so far, we have this 8 group of hospitals that are now going to be accessible to Kenyans next week. So how do you access this hospital? Number one, you must have a referral to that hospital from a provider within the country. So for example, if the patient has gone to KNH, Coptic, Nairobi Hospital, whichever facility, your doctor must refer you to one of these hospitals, not any other. If you're referred to a facility that is not in this list, SHA will not pay. And that is why this list will be available on the website. Once a referral note is submitted to SHA, the provider, these hospitals have been trained, and the claims will now for the first time be done in the system. And shortly, if you allow Honorable Speaker and Session Chair, we want to show you the system in terms of how the system looks like. The provider will be able to go in, they'll be able to lodge an admission for the Kenyan. We will be able to confirm that you're a SHA paid up member. Treatment will then proceed. Upon discharge, the hospital, these 8 of them, will then submit to us a discharge summary and a claim. SHA will then settle that claim, and then you'll be able to come back home. When you come back home, you must come back to the agency hospital. In other words, we are trying to curb Kenyans being referred abroad for other intents other than care. And so these facilities will actually have an agency back home to follow you up and ensure that your care is taken care of. So that is on overseas treatment. This package is at 500,000 Kenya shillings. Any Kenyan who expends more than 500,000 Kenya shillings will have to pay for that out of their pockets. If the costs are below 500,000 shillings, SHA will cater for that and your balances will remain. If you need another visit, we will come to the max of 500,000 Kenya shillings. With regards to the issue raised on rejections, Waziri, you've requested for the list of rejections. I do have the rejections list here, and I'll start with the rejections that have taken place in national government. The national government providers that start with KNH, MTRH, KUTRH, Jaramogi, Kenyatta National Prime Care, Kenyatta National Othaya, Spinal, Mathare, and Defense Memorial, their rejections are as follows. KNH, 268 million. Moi Teaching, 234 million. KU, 102 million. Jaramogi, 65 million. Kenyatta Prime Care, 35 million. Kenyatta Othaya, 6.4 million. Spinal, 5.4. Mathare, 5.3. Defense Memorial Forces, 378. When we look at our counties in terms of rejections...
Sorry, not to interfere, but I don't think you need to be that granular. The CS are
we have
the
this list. If it's required, it can be submitted.
Yes, absolutely.
Yes.
Just let's proceed with the other
questions.
Okay,
great. If we come to the settlement, a question has been asked about settlement of shift claims for our county providers. Currently, SHA owes county providers 6.49 billion for county governments, and this represents 19% of what we owe them. And if we look at the settlement of our county governments, again, we can provide this, but really quickly, Baringo is up to date to 64%, Bomet to 71%, Bungoma to 68%, Busia to 67%, Elgeyo Marakwet to 66%, Embu to 77%, Garissa to 68%, Homa Bay to 78%, Isiolo to 66%, Kajiado to 70%, Kakamega to 77%, Kericho to 67%, Kilifi 73%, Kisii 73%, Kisumu 76%, Kitui 71%, Kwale 61%, Laikipia 66%, Machakos 70%, Makueni 70%, Mandera 74%, Marsabit 67%, Meru 70%, Migori 70%, and that list is available as well and can be shared. Now, when we look at the issue of SHA Lipa Pole Pole, to date, Honorable Speaker and members, 564 million Kenyans, 564 million Kenyans have gone through, sorry?
That is the population of where?
No, I'm saying, sorry, yes, thank you, Senator Mandago. I'm coming to that. So in SHA Lipa Pole Pole, 500,000 Kenyans, I was thinking of money, but now it's population, 500,000 Kenyans have been able to access SHA Lipa Pole Pole, and what have we raised from SHA Lipa Pole Pole? 1.4 billion. How do you access SHA Lipa Pole Pole? You dial *147. When you dial *147, a prompting comes up that asks you for your ID. Once you put in your ID, your means testing is automatically calculated and you get your means testing rate. Once that is then available to the Kenyan, option number 3 will ask you, how do you want to pay for this? Do you want to pay for your premium immediately, or do you want the SHA Lipa Pole Pole option? When you click it, you will be expected to pay 4 months of your premium. So for example, if your premium was 600 shillings times 12, that's 7,200. You'll be expected to pay 600 times 4. That's 2,400 immediately. And this can be done via M-Pesa. Someone can also pay for you, and the system is linked automatically. Once that payment is done, then you'll have a balance of 8 months. That balance you must clear and choose the option of clearance. You can choose to clear it monthly, you can choose to clear it daily, you can choose to clear it weekly. So that's how SHA Lipa Pole Pole works. And so far, 1.4 billion collected through SHA Lipa Pole Pole.
Secretary, the clarification was once I've paid those 4 months, I have access to the full benefit?
Yes, yes. You have access to the full benefit, and then, of course, you must ensure you clear up your 8 months. In other words, any of your constituents who are not able to pay for a premium annually, if they go to SHA Lipa Pole Pole and pay for the 4 months, they can then access care there and then. And their premium is active for themselves and their families and their dependents.
Just a minute.
Let me answer that question. We have got very vital information in the system. I'll give you a good example. We have got your data of KPLC. So if you are paying, the bill you are paying can tell us your income. So once you put your ID card, we have a lot of information, and that information will help us tell you you'll pay 6,000. But there's something that Mercy has forgotten, and it's fraud. Now we are faced with over 26,000 Kenyans who have gone through Lipa SHA Pole Pole. They pay the 4 months. At once they go to the hospital, they give us a bill of 500,000, for example, and they opt out. Yes, and we have the list of their names. And I want to tell them we are coming for them. So now we are working with the telecom companies, and we want to do like M-Pesa. Yeah, the law allows us. So because he pays 4 months, the next month he gets an SMS, he opts out. So 26,000 have opted out. And it's not the individual. These individuals are working in cohort with the health facilities. So they give us a bill of 500,000, for example, and then he opts out. But every trick they do, maybe they will survive for about 3-4 months. Once the system profiles them, then we will introduce something. So the telecom companies are working on how to lock in those people.
Thank you, Waziri. So I'll just continue to assistive devices. Yes, assistive devices. Yes, disability. So SHA has paid out 19.2 million to date for assistive devices, but however, as noted by the honorable member, the assistive devices are yet to be activated for the normal scheme. This is for the Public Officers Medical Fund scheme. And the main constraint here is budget and resource availability, which we will continue to rally for and mobilize to ensure that we're able to roll out assistive devices across the country. Back to you, Waziri.
The question, which is the elephant in the room that Honorable has asked, is that she's saying all people with disability must access free medical care. Okay? Based on the law that she has passed. Let me be very honest, because I'm fasting. That matter, we are discussing it with the Council of Governors. We are discussing with the national government. Because, you know, I agree, the House has the powers to make law, and we are the ones to implement. If we feel that the implementation becomes a challenge, then we have the right to come back to the House and convince and persuade with the facts and evidence.
Waziri, I think we are going to...
Yeah, so I'm just saying...
Order, Waziri, please. Just 1 minute, Waziri. You know you went after Senator Joe Nyutu, saying that we are the ones who passed this law, we must implement the way it was. So when you start telling us again that there are things that you are thinking about, you'll get a lot of objections from the floor. I think let us just, yes, and UHC, the promise was free medical care. Even those 26,000, just please, 1 minute, even those 26,000 that you're saying opt out, Kenyans have to devise these ways because we were promised free medical care. And statistics are showing us, I think the CS for Treasury was in the Senate, saying the numbers they have is that at least 40% of Kenyans live below the poverty line, in extreme poverty, which is 130 shillings a day. My figures from Oxfam were 50%, of course.
No, Chair, I agree with you.
Yes.
The option I'm not saying is not coming back to change the law.
Yeah.
It's even to get the number, the way we fund PHC, whether we can even fund people with disabilities. That's why we're working on the numbers. But I'll agree, we will comply with the law.
Okay.
We will comply with the law.
Let's clear the questions.
Session Chair.
Session Chair. Order, please. Order, please. We will come back to the floor, please.
There's
are
some
there
clarity.
questions that are remaining? Yes,
The only
Dr. Mwangangi.
Yes, so the only other question was on primary health care. As highlighted by Waziri, we will soon be paying out arrears that we have on primary health care. However, as it stands, Nairobi County has received the highest payments at 1.3 billion, Kiambu 754 million, and Mombasa number 3 at 597 million. With 57% of all PHC budget, that's about 13 billion going to county governments. So the question of FIF becomes very, very critical.
Chairman. We will come to the floor, please. Is there anything from this side?
Maybe just to add, Honorable Speaker, Honorable Members, on the maternal mortality that Waziri spoke to, that as a country we don't have recent data, and we have commenced on a survey called Reproductive Age Maternal Mortality Survey to be able to tell us the numbers of mothers who die in this country. That is estimated at about 5,500 per year. And the leading causes of maternal mortality include bleeding, and especially bleeding after giving birth, which is called postpartum hemorrhage. That accounts for 40% of maternal mortality. Number 2 is hypertension or high blood pressure in pregnancy, another 17 to 20% of maternal mortality, then infection, then unsafe abortion, and finally obstructed labor that Senator Muma spoke to when she talked about adolescents who are not mature enough to be able to carry a pregnancy. And therefore what we are doing is to be able to increase the number of regional blood transfusion centers to ensure that blood is available throughout the country. We are also doing capacity building of the health workforce to ensure they can be able to respond to emergencies, training in basic and comprehensive emergency, obstetric and newborn care. We are supporting the counties with the health products and technologies, including heat-stable carbetocin to stop bleeding, magnesium sulfate to control convulsions, and also caffeine citrate to be able to assist newborn babies who have a difficulty in breathing. And finally is, of course, advocacy through even new political leaders so that this becomes a national discourse. Thank you.
Senator Mandago, please, I beg you, let us clear this side, then we will give you the closing.
Just clarification on what they have answered, because they will not come back to those questions.
Yes.
One item, CS, we are now very clear on the issue of UHC staff, but there were 94 staff who are deployed to counties to support the TB program, Global Fund, who are not part of the UHC. Are they part of the people who will be cleared so that we are through with that problem? Then number 2, Mercy has answered on the issue of foreign treatment, a maximum of 500. Maybe what we would like to know from the CEO of SHA, how did you arrive at 500,000 for foreign treatment when on average cancer treatment outside this nation is anything between 1.5 to 2.5 million? The bills we pay locally here for other ailments, SHA compensates even up to 1 million Kenya shillings. So how was that arrived at 500,000? And on that matter also, CS, I thought policies and laws are not applied retrogressively. When this policy was rolled out, we already had Kenyans who had their children receiving treatment in foreign facilities. And the service was abruptly stopped. They already had authorizations from government for that kind of treatment. And a number of actually mothers suffered because they were not able to settle the bills. They had to stay with their children a longer period in foreign hospitals before fundraisings and other measures are taken. Why was the policy implemented retrogressively? Instead of us at when it was rolled out, you begin the process.
Thank you. As the chair of the health committee, I've allowed him 3 questions. Now I'm coming back here. Please, please, please. 1 question straight to the point. We'll start with our host senator, Senator Kiroche.
Thank you, leader. I think my first question was the same one.
Just one question.
Yeah. No. I just want to clarify that my first question was the same one that Senator Madago asked, because it is true. There's 3 elements that they've already categorized, that 9 of them. To go to abroad, those are the terminal, maybe most of the difficulty diseases that they cannot be treated here. So to go to abroad, everybody knows it will be very expensive. So asking the CS whether that back package can be improved to meet those patients, because I think then the next one is already no. I was just concurring with Senator Madago. The next one now, I'm the host senator. The next one now is only one, is that the CS said very clearly that they already know the capacity of a hospital beds from their desks. So how do we end up having patients, 3 in a bed? And here in Nakuru, it's known, even 3 maternity from giving birth, they are sleeping 3 in one bed. And then the other, that's for facility improvement fund. Final facility.
Which hospital are you talking about?
They said all the hospitals, they know the capacity of the beds in all the hospitals. Okay. Even here in Naivasha, if you go, you find 2 people. For me, as a senator of Nakuru, I keep on going to these hospitals. You find 2 shared in a bed. The final one, facility improvement fund. Facility improvement fund. You've thrown it to us. Because I saw you saying that to your senators to support you. But I've seen you go around. I've seen the effort you put on 6.18 billion. Let me finish. 6.18 billion on National Equipment Support Project. You've done 120 hospitals. And I've seen you come here in Nakuru. Is it that you don't know how much is collected when you're going to those hospitals? For your information, facility improvement fund here in Nakuru is 1.2 billion annually. So if you went to 120 hospitals, I think Nakuru could be helping even other hospitals to put those equipment.
Thank you. Now, if the next senator behaves the way that our host has behaved, I will close the session. I get very irritable around lunch, and you know it. Senator Ogun, please, straight to the point.
Thank you. Silence. Honorable Waziri, has SHA organized a package for cases for people living with HIV, or we have left it to donors?
Thank you. Very well done. Yes, Senator Beth, we will come across the room.
Thank you, Senator Beth from Kitui County. Bwana CS, SHA is good and working, but my question is, there are so many claims and issues about corruption. What is your strategic step towards curbing the corruption in SHA, in its facilities and individuals?
Senator Lelegwe, we will come to you.
Thank you, Chair. I have only one question. What measures has SHA taken to address cases where claims are submitted for medications that were not actually dispensed to patients?
Thank you. Clear and straight, Senator Wakobubi.
Thank you, Chair Session. My question is pegged on SHA, PHC fund, and critical care fund, that most of them have a limit and they have a capping. And therefore, sometimes it becomes not very much affordable by some of the patients. So can the ministry devise a method of flexing some of these?
Thank you.
And
Senator,
finally, we are still having devolution struggles. This is the 13th year in devolution. We demand for affordability, accountability, and access.
Thank you, Senator Mtata.
Yes, Honorable Minister, my question, listening to your submissions, you raised an issue of dispute in terms of claims that are filed with the SHA, with the chief, really, it's really under chief. Now, under Section 43 of the SHA Act, you have got the Dispute Resolution Tribunal. Have you operationalized that tribunal? Yes, sir. And how do you end up yourself deciding a dispute? Like if, say, the General Hospital in Mombasa made a claim that you don't agree with, do you stay in that dispute to the tribunal, or do you, as a minister, decide and say we are giving to law enforcement?
Fantastic
and
question.
just as I give out, 104 billion is in the contract you people signed with the suppliers of this system, and I'm litigating it in court. These are facts. So you cannot run away from it, my Honorable Minister. 104 billion shillings is being paid by the government of Kenya.
Asante, Mheshimiwa Rais. Mheshimiwa Murachi.
Thank you, Session Chair. My question to the CS will
Chair,
be, how many levels...
You are unanswered and you are saying Mheshimiwa Rais. We have only one Rais in this country.
It was on a light note, Madam, please.
Okay.
Protect me, Chair.
Miraj.
How many level 2 and 3 facilities are fully compliant of the Green Charter? What penalties exist for facilities charging illegal fees at this level? And what are the compliance, how is the compliance monitored?
Thank you, Senator AC. We are done here.
Thank you. I wish.
A comment.
Excuse me, the floor is mine. I have a question. Waziri, I would wish to know the implementation status of the enhanced SHA oncology benefits.
Senator AC Okenyuri.
Yes, the implementation status of the enhanced SHA oncology benefit package, because the cancer patients at the moment are not able to access the 800 shillings thousand cover at this particular moment.
Thank you, Senator AC. Let's go to Senator Wambua.
Thank you, Chair. My question goes to Director General Patrick Amoth. How do you plan for the deployment of human and capital resources to reverse maternal mortality if you don't have up-to-date data?
Thank you.
Chair, my leader has left me with a question which is written. Let me ask this question on his behalf.
Proceed.
This question goes to the CS. The CS, my leader, Senator Mazayo Kilifi, wants to know when you plan to remove the bodies recovered from Shakahola, which have been dumped inside a container outside Malindi Referral Hospital.
Thank you very much, Senator Kisang.
Good, thank you, Chair. Mine is to the CEO SHA. I wanted to find out what plans does she have to ensure those who have registered as members of SHA and are not paying, pay, because there is a big gap between those who are paying and those who are registered.
Thank you, Senator Recha. Senator Hilary.
My question, I think, goes to the CS Health, or General anyway. What measures are you taking to eradicate patient detention as a result of not being able to clear bills?
Very good question. Senator Hilary Sigei.
Thank you, Sifuna. Waziri, you've made reference to FIF being one of the problems, which it's a challenge. 2 weeks ago, my governor admitted that they have been illegally getting 25% of the remittances from the facilities to CRF or to an unknown account. What do we do? You've thrown it to us. That is a question most of us have asked here, because it's a big question.
Next is Senator Montet. We are coming row by row. We will get to the
Thank you, Chair. Mine is the number of rejected claims is escalating. So very soon, SHA will be told that it is not working. So what I'm asking, we are told that most of these rejections is due to documentations. What are you doing to simplify administrative documentation, especially to the rural facilities?
Thank you, Senator Paris. The ladies are really behaving well this side. Just one, please, kindly.
Kidney medical bills that are running into millions.
Thank you. Thank you, Mofaya. Senator Mofaya, please.
Thank you, Session Chair. Waziri, the discontinuation of Linda Mama program has led to a regression in maternal health care, as is in Kenya, which is important to.
Please don't read. Just
I'm not reading. I'm quoting.
Yes, please.
We have very many mothers retained in hospitals. So, what is it that is doing to make sure that we have access to this kind of program in future?
Thank you, Chair.
Don't be reading.
Just repeat your question.
I am saying the discontinuation of Linda Mama program in Kenya, discontinuation.
Asante, Senator Mbugua.
Thank you, Chair. Waziri, when we re-ministry table to Parliament the national policy for identifying and enrolling indigents into the SHA system. Thank you.
Thank you, Senator Ezena.
Thank you, Whip. And this question arose from my community engagements in Samburu, and the residents would like to know what has SHA done to ensure inclusivity of under 18-year-olds who are totally orphaned and have no primary dependent. Thank you.
Thank you, Senator Eddy.
Waziri, may you explain to the country the rationale for denying services to patients who have not made a full year contribution, even when they have contributed up to date at the time they are seeking treatment?
Thank you, Senator Hamida.
Thank you. Bwana Waziri, what is the status of the unpaid debts and unsettled claims so far from NHIF, which still lingers and has not been resolved?
Thank you. Last but not least, Professor Tom Ojenda. If you had already asked a question, please allow your colleagues to go. Let's hear from Professor Tom Ojenda.
Thank you. To the CS, this is a question that is generic. CS, what is the status of the saga involving the Kenya Medical and Practitioners and Justice Council, KPMDC, and the demand by KPMDU that you disband the council?
Thank you. Thank you, Prof. What is this comment that is banning Senator Beatrice? 1 minute, please.
Chair, I was just requesting Dr. Mott to add negligence as a cause of maternal deaths in this country.
Thank you very much.
And it is critical. Yeah.
Asante sana, senators, for making my life easy. And I apologize if I have cut anybody short or cut anybody out. We are running out of time. CS, please let's take those responses and then we'll hear from the governor from Mombasa.
I think I'll start with the senator and chair. Global Fund staff. There are not many. There are about 90. We have factored them in our budget this year, and once that's finished, we will they'll be back, and we will pay the budget will be from July last year. And then on the issue of let me say these honorable senators and honorable speaker, that the foreign treatment for many years in our country later became a cartel business between doctors in India and some also doctors in Kenya. There were certain treatments that can be done in our country. Kenya is one of the countries with the highest human capital. So the Benefit and Tariff Panel Advisory Committee, working with the DG, have flagged out only 37 ailments or treatments that Kenyans can only go out of the country. And that one I have gazetted. So if you want to go out of the country and pay from yourself, you have no problem. But if you want to use public resources, your own insurance, and the SHA, it must be within that 37. On those who were there before the disbandment, I don't want to again go into trouble with the chair. Honorable Chair, you did not put the transitional clause. When you are transiting from NHIF to SHA, that should have been captured in the Social Health Authority, a transitional clause that says those who are out of the country, and that was all done. So a new outfit was created called SHA. So we have to live with the new SHA rules. Then now I think there were 3 hospitals you said on bed capacity, and I think there was somebody who asked. Let me just answer. Kenyatta National Hospital, one of our biggest referral, had a bed capacity by law of 1,800. But they used to admit 2,200 and allow people to sleep on the floor. Today, if you go to Kenyatta, they can only admit 1,800, and nobody's sleeping on the floor. So if you see any hospital, an hospital these days, they don't see the urge to put 2 mothers on the same bed or to sleep on the floor, because SHA will not pay. SHA will pay. So before, the urge was because of the former NHIF. NHIF was paying for those who are even on the floor of the hospital. On FIF, I think also somebody asked. I think from my previous experience, national legislation is superior to county legislation. There are some counties that have created their own FIF. And the governor here is saying it's true. The Senate must be very firm and say that the law that will exist is the FIF Act legislated by the Senate. Those governors, they must be told in black and white. I have tried, but they don't want to listen. Honorable Wakoli from Bungoma, I think Mercy will ask. We have a plan on how to integrate HIV into SHA benefits, but you'll speak to it. Senator Betty from Kitui, I think. Yes, the biggest challenge we are facing is corruption. Not only in facilities, even in our own institutions, KMPDC, even in SHA, but we have made it very, very clear that there are no sacred cows. We even have corruption in faith-based facilities where we expected the highest standard of ethical. So we will, yes, there's one in Likoni that I thought it was owned by the governor, but later it became owned by a faith-based, and we are about to do it. I think the senator for Samburu, maybe I didn't get it, but it was about missing medicine in the facilities.
Issue CS was, somebody goes to the hospital, there is a prescription for drugs, they don't have that drugs in that facility, they have to go and buy, but when the hospitals are claiming, because it's already on their records, they also claim the money for...
No, in fact, what is happening, and this is going to shock you, our system has detected in 5 counties, I don't want to name them, but let me name the first one, because the governor has agreed with me, Kakamega, that 52,000 patients went through the system, and only 9,000 got drugs. We went to another county, 36,000 they went to the lab, they saw a doctor, but when it comes to dispensing of medicine, only 4,000 got it. The question is, maybe the healthcare workers in that facility, and that's why you see, I don't want to use again another example, in a number of our PGHs, the compound is surrounded by chemists. Every hospital, PGH in every county, you see around the hospital, there are over 200, 300 pharmacies. Those pharmacies, the drugs they use are the ones stolen from the hospital. So what are we doing? Now the system we have designed, and Anthony is here, is going to maybe speak to it, that if you have not dispensed a drug or a medicine to a Kenyan patient, SHA will not reimburse. It will help us in 2 ways. When SHA does not reimburse, the amount of money goes down. So you'll be forced to have the medicine. But this problem is there. And please look at even, I can name a number of counties I've visited. There are more pharmacists than even the buildings there. So we will we'll deal with it. There was a question by our nominated senator that I leave it to Mercy. Honorable Mtata, the issue of tribunal, you are very much aware. For us, anybody who wants to defraud SHA We have, under law, we have the powers to suspend him. We have powers not to pay him. And all facilities have dashboards. They can see why they are rejected, the reasons, the claim. And I want to say, since then now, what we have done is that now the system has improved. It won't accept your documents if there are documents missing. It will tell you, no, bring that document. So the rejection has reduced by about 60%. Kenyatta National Hospital, for example, the last 2 months has not filed any rejection. So we are also doing, SHA is doing clinics, Mercy will speak to it, where we are educating hospital claims officers and admins to do that. The tribunal, it's the judiciary that has brought a law to Parliament. I think it's in the National Assembly, where they say we want to consolidate all tribunals into one. And we have been told not to operationalize. Tomorrow, if both houses finish that consolidated tribunal of the judiciary, I will operationalize. People can go to the tribunal. But for now, I have to protect public resources. On the 104 billion, that is a matter in court. We are with you in court. We will argue our case in court. You'll argue your case in court. And the courts will make a decision. I think it's not for the Senate. Honorable AC, I think oncology, yes, 800. Mercy will speak to it. But you know, even after the pronouncement of the president, we are ready, willing, but we must follow the law. So the benefits and advisory tariff panel is we're doing public participation. We don't want, again, somebody to go to court and over how we spend money. Honorable Ambo, I think your first question was to DG. DG will answer. The question of Honorable Marzayo, I think, is a public health risk and threat. And I agree with him. And I think, DG, you must pick it. Yeah, we must sit with the Ministry of Interior, and we must bring to conclusion those bodies. You can't have bodies in a container for all these years. It's going to be a serious public health threat. And we're the custodian of public health. So we will pick it up, and you will see it. Honorable Member, our Senator from Elgeyo Marakwet, I think Mercy will answer that. Senator from West Pokot, patients detained. Patients are detained for many reasons. But I think it's not right for patients to be detained. For example, Kenyatta National Hospital, we have a fund, a disaster fund, and when we confirm that that patient cannot pay, we use that fund. We even used it during the many riots in Nairobi. But Senator, you need to help us. Because of the strike in Nairobi, our referral hospital is overwhelmed. And we have written to the governor a number of times. We have written to the governor. He needs to resolve that dispute. The same with Kiambu, when there was a long, many months of strike in Kiambu. We had the same problem. The Kenyatta Hospital and Kenyatta University Referral Hospital overwhelmed. So you need to help us. Honorable Senator Tobiko, burden of extra cost. The 500, Mercy will answer that. I think I have finished mine. Maybe Mercy, and Mercy, you must speak a bit louder for the senators to hear from at the back.
And a bit faster.
And faster.
And
okay.
yeah, there was a question by the senator nominated senator from Mombasa.
Senator Miraj.
Miraj, what was it?
The number of facilities that have complied with the Green Charter, penalties that exist with the facilities that are charging illegal fees, and the compliance, how the monitoring of compliance is made.
Mercy, you take that. But there was a question by the host senator, I forgot, on Nakuru. She's very busy with the phone. Yes, number one, I want to say that Nakuru PGH is the best in terms of compliance. I am proud of the doctors and the people who run in terms of claims. They have some rejection, but I think after Nairobi's, after Nakuri's Nairobi and Mombasa, we have received over $1 billion or close to $1 billion. Nakuru has received 1.2, 1.3. I think now they have reached 1.5 billion. But I agree with you that please report to us. Report to our call center, 147, either email or telephone or WhatsApp, if you see that there's a facility where our patients are sharing beds, because that's illegal and that is not care and that's not dignified. When two people share a bed, that is not care. You're not giving them any care. So please help us. And then the one on the FIF, I think the governor is here. This thing is going to land me into problems. This should be a discussion between the governors and the Senate and the legislature. So Senator Abdul Samad will answer what is happening with FIF in some counties, maybe not his. Mercy.
Thank you. Thank you, Waziri. Thank you, Session Chair, Honorable Speaker and members. On the overseas program, this is progressive. UHC globally is progressive. And Kenya is starting with a 500,000 package. And with more resources, with more registration and payment, this package will be improved. The process of doing this is through the Benefits Advisory Tariff Panel, led by Professor Jauko. He has already started a process of review, and he will be inviting and also interacting with this House in terms of enhancing the benefits. In terms of the old NHIF pending bills, both overseas and national, one, we have finished verification of all bills under 10 million, and these will be paid out. We are hoping to get resources in the coming supplementary budget. And we've already started, again, verification of bills overseas, which come to about 125 million, and those that are local, that are about 24 billion. And that process is underway. With regards to people living with HIV, this is how our benefit package looks like. If you have HIV, you're able to access inpatient, outpatient services, radiology services. You're able to get your medications through the medical bed rebates. If you require any surgical procedures, you're able to get those surgical procedures. If you require any dialysis in case you have kidney failure or issues to do with the kidney, you're able to access the dialysis package. So our package as is right now is actually accessible to HIV patients. Remember, HIV in Kenya is a strategic program, and we do have the commodities availed through the Ministry of Health. Progressively, what are we doing? In collaboration with USG, we do intend to ensure that the reimbursements for medicines for HIV will also be included in the SHA package. And we have the costings for that. We are working with the PS Medical Service to ensure that takes place. Yes, and DG is telling me here that 97% of Kenyans living with HIV have achieved viral suppression. And that's a good indicator in terms of how our program is working. Then the PHC fund. The PHC fund is funded through what we call global capitation. And honorable members, here's where we need your support, because if your counties register, it means they get more PHC resources. Counties that are below in registration are actually getting very little PHC resources. As we stand right now, Samburu is second last with just 28 million, while Nairobi has gotten 1 billion. And it's all a factor of your registration. Number two, if you look at the Emergency Chronic Illness Fund, again, this fund is accessible to all Kenyans, and you do not have to have registered for SHA. If anyone has an accident, you're on a boda or any type of accident, and it's an emergency that fits our benefit package, you can actually walk in to any level 6, 5, private public FBO facilities and get care for the first 24 hours on the account of government. Now, past 24 hours, your shift would need to kick in to be able to meet your bills. With regards to the green charter and the green label for level 2 and 3 facilities, we are mapping out compliance, and this is being done through the county SHA branches. As it stands right now, we are aware that some counties are co-charging, and we will soon be able to release that list once we finish the compliance mapping. With regards to implementation of the enhanced SHA benefit package, again, this process is being led by Professor Jauko. He is intended to give to the Cabinet Secretary an advisory by 1st of October this year. That advisory will have the packages that will be enhanced and the ones that will be reduced. And so active participation will be required, so then we have now the next version 2.0 benefit package. When it comes to registration and payment, indeed, the honorable member is correct. We do have Kenyans registering, and we are working to ensure that those who register do pay into the fund. We have different activities that we've rolled out to this regard, including deployment of our SHA offices, compliance, messaging, communication on the benefits of enrolling into SHIF. Patient detention is illegal in Kenya. We're not allowed to detain patients, and any providers who are detaining patients, particularly on the basis of SHA, would be doing that illegally and would go through the system for that. In terms of raising medical costs, again, UHC is a journey. We have to work continuously to contain medical costs, and they escalate everywhere globally. Estonia has 14% of their pay slips deducted for their healthcare. Singapore has 10%. Kenya is at 2.7%. So it's a progressive journey that countries continue working towards to improve the resource basket for UHC. Now, under 18-year-olds can be registered through their households. However, those who are orphans and do not have principal members can also be registered and can access SHA, and we'll be able to provide that information on the website. We also do have covers for orphans, and that's at 300 Kenya shillings for the orphan, and they'll be able to access all services. With regards to full year contributions, this is in the law. The law provides for annual premium payment, and the reason for this is because if we look at NHIF, Kenyans used to pay 500 shillings, access a surgery for 100,000 shillings, and then never return to pay. This then meant that the fund was unsustainable, and that's why we have the annual contribution. For Kenyans who cannot afford the annual contribution, we have SHA Lipa Pole Pole, and on the direction of the minister, we've also expanded this to include other insurance premium financing facilities that will soon be unveiled to all Kenyans. Regarding NHIF pending bills, as highlighted, 5.3B has already been reviewed and will be included in the upcoming supplementary. Then we'll get to bills above 5.3 billion for facilities who have bills above 10 million. In terms of maternal deaths, I think DJ will touch on that. The emergency package being available in all level 6, 5, and 4 hospitals that have theaters. Again, this list is available in the SHA website and will be disseminated to everyone. The oncology package, as highlighted by Waziri, yes, the 800 limit is now in the system. We'll be going through public participation, submitting the regulatory impact statement, and getting this on legal notice so that Kenyans can access this. We anticipate this should be done within the next 2 to 3 weeks, so that this package is now available for Kenyans. I will hand over to you, DG.
Rejected claims escalating.
Sorry? Yes, so the trend is actually the opposite. Rejected claims are decreasing, and if we give Anthony a chance, he'll be able to project the system. He'll log in and you'll see in the system. Rejected claims are actually decreasing. And why? Because we are rolling out what is called the HMIS. Providers will now be able to log directly into the system through a HMIS portal that will reduce the number of rejections. Number 2, DHA has put in what you call OCR. In other words, when you put a discharge summary and you haven't filled it in, it's rejected. So the claim doesn't even come to SHA until you fill in the right documentation. And that has drastically reduced the number of rejections across the country.
Thank you. Dr. Amoth, quickly.
Thank you, Senator Wambua. The reason as to why we did not have this data is that we jointly do what we call the Kenya Demographical Survey, a periodic survey carried out every 5 years. Maternal mortality was not captured in the 2022 demographical survey because KNBS advised that we are going to use the 2019 data, census data. When they went back to the census data, there were quality issues, and therefore they could not be able to project maternal mortality ratio for the country. That is why we are doing the reproductive age mortality survey. But going forward, the digitization process that has taken place through DHA, we have real-time data now. For example, for SHA, for all deliveries that happened from October 2024 to January 2026, nearly 900,000 deliveries. We know those mothers by name, by ID number, by health facility, by sub-county. In fact, we are the first country in sub-Saharan Africa, if we implement this full-time, that will move away from the periodic 5-year survey to real-time data that we can be able, at a click of a button, to access. Then, Senator Beatrice, yes, what I mentioned were direct causes of maternal mortality. Maternal deaths are classified into two, direct and indirect. Anything else from negligence, ignorance, violence, falls under indirect causes of maternal mortality. Thank you.
Thank you very much. We want to give the Chair of Health a very brief comment and then...
But Chair, my questions were not answered.
Who is talking?
Senator Miraj.
I'll throw you out. It's lunchtime.
Surely my questions are not answered.
Waziri, which question is this that has not been answered by...
I push it to Mercy. Oh, what did you, maybe I can, what was
Just
it?
take the question again quickly, Senator Miraj. Please,
Senator
we have had very
Roma,
comprehensive answers. As you just find...
I asked about penalties that exist to facilities that take illegal fees. I also asked the models, the compliance.
Okay, what we're doing, particularly for PHC level 2, level 3,
yes,
and part of level 4, for outpatient Kenyans who are registered with SHA, we are putting a charter in every facility, green charter. And the top of the charter is walk in, walk out. And then it shows all the services available, and in front of it, it's written free, free, free. And then Kenyans now can get an SMS whether they got that services. So with the charter at the beginning of the hospital, nobody can go charge, but even leaders can help us in your functions.
Waziri, I had heard that if you ask for money, you call the police. I don't know if that's what she's asking. Dr. Mwangan.
Oh, if you ask for money, you have the right to report to 147, our call center. You can even report to the police.
Chair, the union and the council, the CS did not answer.
Please, if you have an intervention,
the union and the council, KMPDU and KMPDC.
Order, Senator.
Yes.
Question.
That's an important one.
Very, very important question. When I went to the ministry, I found something very strange, that the chair of KMPDC himself was under investigation by KMPDC because of a patient malpractice, because of his hospital, and he was appointed the chair of the board, so I had to remove him. Now, what we have from the union is audio which is circulating, where one member of the board is soliciting for bribe from one of his colleague doctor, purported, who has a case, a professional misconduct case with the council. I've asked Professor Were, a renowned, respectable medical practitioner, and who has no facility, as the chair of the board, to call a board meeting. They did yesterday. Their recommendations are on my table, and I will act on them. But I think you have seen also yesterday of the people the DPP has said they must be prosecuted. There was an official, a staff of KPDC. So healthcare, fraud in healthcare is a wider ecosystem. It's a facility, it's systemic. We're dealing with something which has been happening for 60 years. NHIF was there for 60 years. So from the facilities to the regulators to everybody, we are busy cleaning up. We have even no time to sleep. But I am sure once we make a decision and we find out that this is it's true and the board decision, I'll take action on Monday.
So you will disband?
Thank you.
And of course, I will not listen. I've listened to the sentiments of the union, but that will not make me take action. I think I should also get the views of the board.
Thank you. Let's hear from Senator Mandago.
Thank you very much, Session Chair. Mine is to the Chair of the Health Committee at the Council of Governors. Cumulatively, counties owe KEMSA 3.5 billion. Mombasa County owes KEMSA 17 million. What are you doing as Council of Governors and Governors to make sure that this money is paid so that the issue of the fill rate for KEMSA can be enhanced. Any non-payment directly affects the capacity of KEMSA in terms of fill rate. And to PS Oluga, because you are here, what are you also doing? Because your ministry owes KEMSA 2.5 billion.
Okay.
It's a debt that has overstayed. Finally, I want to leave the CS and his team with some assignment and SHA. CS, we have state corporations, parliament, and other agencies that still enjoy private cover from insurances. And we are spending billions of money, which is also government money, on medical insurance. When you visit a facility for treatment, like myself, the first thing they do is to charge SHA, because I'm also a paid-up member of SHA. They charge SHA first. So if my bill is 1 million, whatever SHA is supposed to pay, if it is 400, they remove 400 from SHA. Then the private insurer, whom we have also paid millions of money, now pays less. My ask is this: can that be reversed so that any government officer, whether state officer working in a parastatal or anywhere, and have an insurance cover that has been paid by public resources, the first charge should be on the insurance. And if the cover is able to pay all the amount, we can recover first from the insurance. Once it is over, we can now come back to SHA.
Thank you, Senator Mandago. With that, Governor, we will bring you in as the chair of COG. Just make your brief comments, answer the questions that have been directed at you. We are going to close at exactly 2 o'clock in 3 minutes' time.
Maybe I start with Senator Mandago. He asked about, first of all, I think the issues with KEMSA is not even just money alone. I mean, for the longest time ever, they were the single entity that was supplying to counties, and the problem has always been on management. And I think the ministry has taken necessary action on that. It is true Mombasa has a debt of 17 million. 17 out of 3 billion of all counties, the county of Mombasa, since you mentioned it, is a very, very tiny percentage, and it's actually a working. It is not something that is stagnated. But there's a discussion that we have had. Other discussions that we're currently talking about is where FIF can be able to be used as guarantee to pay back. There's a modality in law that we are trying to work out. Instead of deducting at source, which is in another illegality, we are trying to work out on something that we can be able to use that funding as some form of guarantee. But quickly, maybe, and I'd like to just touch on issues that it is important for senators to take note on. One, the UHC, the Council of Governors together with the Ministry of Health, our position collectively to SRC has been that for us to be able to absorb the UHC workers, SRC, when they're not SRC, the Commission for Revenue Allocation, when they're presenting the amounts that are due for counties, the division, it is important that the minimum should also have that figure, which I think is about 9 billion shillings. It is important for that figure to be there. We cannot continuously have UHC staff being relied on conditional grants, because then what's going to happen 6 years, 7 years, 10 years down the line, when you have regime changes and someone decides that they don't want to pay conditional grants, it'll be a problem that we will not be able to handle. Two, the issue of the SHA, I think SHA is working. What it was a few months ago is not what it is today. And it is still work in progress. Some of the issues, and I'd like, because we already have a committee that we have proposed together with SHA to handle majority of these issues like high rejection rates and so forth. Some of them have been a system failure here or there, so we're working on these particular matters. There's something else that we will need the support of the Senate. Right now, public health, there was an initial decision because of the cost element. When births and deliveries are done in a level 2 and a level 3, there is a budget element that is involved in it. I'm glad that the Ministry of Health has already proposed, and it is in the current supplementary. So once that supplementary has been able to be passed by Parliament, it means that we will now revert back to women being able to give birth in level 2s and level 3s. Otherwise, SHA will not be able to cater for that cost without exchequer support on it. Regarding the Disability Act, this, I think, there's a conflict in laws, because there's already an FIF law that was passed, a national legislation, which county governments right now are basically copycatting the same. But I think there was someone forgot to realize that this is actually a money bill. When they were doing the Disability Act, it is actually a money bill, in the sense that the right thing that needs to be done is the census that has been taken for everyone who is living with any form of disability. Then they should have their premiums paid to SHA. In that way, anyone can go to any facility, and that facility can now be able to claim. Otherwise, you have another law regarding FIF where everyone has to pay. And then there are now rates that are set by relevant county assemblies as well. So the right way to go about it is to allocate enough revenue for every person living with disability, so that we can be able to make this law active and without having any issue. There was something that was raised about patients sharing beds. It's illegal. I want to say this because it has even happened in my own county of Mombasa. And of course, we need to take relevant management action on those who do this. But I'll tell you how they managed to do it. What happens is a patient has been discharged, and the bill has already been closed, and SHA has a certain share that they have to pay, and there's another amount probably that the person has to top up. So that amount that that person has to top up, they say that I don't have this money. And some hospital administrator decides that you will be detained there. But at the same time, there are more people who want to give birth. There are more people who want to use those facilities. In that way, on books and on our system, it shows that we actually do not have those patients, but their patients are actually there. That is the major reason, and that is how it actually happens. There is something that was asked, I don't mean to answer on behalf of SHA, but there's something that was asked regarding the issues of rates. You know that the rates are a bit low. I didn't hear it being mentioned, but one of the proposals that has come out very, very clearly is oncology. Figures will be now shooting up from 500 to 850,000, which is a big boost on this. And also, this is an ongoing process. One of the other things that I'm sure that they're working on right now, because it will affect facilities, is the amount of money that have to be paid to for lab services. I think this is a discussion that is ongoing as well. The issue of level 2 and 3 charging, there is pay cash for this, or we have a special registration for SHA using that facility so that they can be able to use those specialized facilities, including non-communicable diseases. Senators, you might also want to be aware of, if you look at the number of patients that visit facilities on a yearly basis, you will get shocked by realizing, and you'll say that, is it possible that every single Kenyan is sick? A classic example is a county like Mombasa. Those who visit our public facilities are more than even the population. But when you look into the nitty-gritties, what it means is that we have more people who visit our facilities because of non-communicable diseases. High blood pressure, diabetes, of course cancer right now that is on the rise. And I think what SHA needs to, and the ministry, what they need to start working on currently is how we can inculcate that spirit of thank you very much. of ensuring that people do not engage on things that give them diabetes and so forth, because it is a huge burden on SHA and likewise. This, lastly, I just want to state here that with everything that we've discussed, Mr. Speaker, kindly, if there's going to be any stalemate at any given time between the National Assembly and the Senate, because of these things, that we will depend on exchequer. If there's going to be any stalemate, it is not roads that are not going to be built. It is not a hospital, it is not a school that is not going to be built, but it will mean that people are going to have to suffer in terms of health. And lastly, I want to take the opportunity to apologize on my delay. There was a change of time. I think it was actually done very last minute. I had to get a very early morning flight to come to Nairobi, and the traffic, I pity. It is a very short distance for that level. And then I think today there's, I know there's a number of senators you will be missing in the afternoon. I'm told I've seen political rallies being mobilized in the streets that created quite a bit of attention. I know that's why you're rushing us, but okay. But thank you very much. Asante sana.
Thank you very much. With all due respect, I want to bring this session to a close. We want to take this opportunity to thank the entire team from the ministry led by the CS, Daktari Amoth, my sister Mwangangi, my brother in arms, the PS, the senator and the chair of our Committee of Health and the chair of COG Committee on Health. Tuwapigie makofi. Asanteni sana. Mheshimiwa Speaker, nimeona vile kazi yako inakuwaga ngumu. So nataka niseme kama nimekukwaza mahali as a senator, naomba msamaha. Hii kazi ni ngumu lakini tumefikia kikomo. I want to make a series of announcements. When we leave here, we will it was on a light note. When we leave here, we are going to do a photo session. We will have our speaker with us, of course the senators. CS, we are requesting that you join in that photo together with your entire team from the ministry. Governor, if it is not too much to ask, you join us for the photo.